Okay, so we'll get started here. So thanks everyone for joining once again for the Cross Canada checkups and on the Tuesday night editions that we're doing in collaboration with the CPA. So tonight we have Priscilla and Alana who are going to be talking about some of their work in providing services in northern Manitoba First Nation communities and really delivering care in Indigenous and rural communities, because at this time, even delivering healthcare or providing services in cities and large urban centers is difficult enough. But providing care in these rural and remote areas has additional layers of complexity. So we're really excited to hear you guys talk today and hear from your experiences and learn from your experiences. And just before I pass it over, so we had Sandra on last week. Next week, we're going to be having a few of the board members of the CPA come on and answer some questions, and they're going to talk about some of the initiatives that they're involved with. And then this Thursday at 7, we're going to be talking about reopening of clinics and kind of going through different strategies that are being rolled out across the country. So we're looking forward to seeing you at those two sessions. And Priscilla and Alana, I'll pass it over to you to kind of introduce yourselves and maybe tell us a little bit about what drives you to do this type of work as well. So thanks for being here.
Awesome. Thank you, everyone. Thank you to Phil and Mike for having us on your webinar today. My name is Priscilla Flett, and Alana and I were going to be presenting on impact of COVID-19 and providing physiotherapy service to northern Manitoba First Nation communities. So just to introduce myself first, I identify as an Indigenous person from York Factory First Nation, born and raised in Churchill, Manitoba. So hopefully later on I'll show you a map of where that is in Canada. I was born and raised in Churchill, moved down to Winnipeg to finish up my high school. I completed my undergrad at the U of M in physical education, and then continued at the U of M for my Master's of Physical Therapy, graduated in 2018. Since then, I hopped right into my work at Manitoba First Nation Education Resource Center, which I'll be talking a little bit more later. And we provide services to school-age children at communities. I'm just going to share my screen. Let's see if I could do this on. Oh. All right. Can anyone see our slides? Perfect.
Yes.
All right. So I hope that was a good introduction. And what kind of motivates me to work with this population is I love giving back. I've grew up in the northern isolated community, so I could kind of say I kind of know what's going and how people feel. So we're just going to get started. Before we start this presentation, I just wanted to start with this land acknowledgement. And let's see here. So we must recognize our history as settlers, newcomers, and First Peoples of how we came to live together here in the Red River Valley. Winnipeg is located on Treaty 1 land. Treaty 1 is the first written agreement made between settlers, newcomers, and First Peoples of Manitoba. Treaty 1 includes the territory of the Anishinaabe, Cree, and Dakota people, and it also includes the homeland of the Métis Nation. As settlers and newcomers, we have an important part to play in telling the truth, especially when it comes to harms and mistakes about history. Recognizing and learning about treaties helps us honor the agreements made between all peoples in the Red River Valley of Manitoba and across Canada. Working with Indigenous communities can help ensure that we all have a future to be proud of and stand by. When someone listens to one another, we can solve issues in a spirit of friendliness. This way, we can all live happier lives. There we go. So this is our agenda. I'm going to be talking about my clinical practice and how it's been impacted by COVID-19, providing physio services to school-age children. And then I'm going to touch a little bit about Jordan's principle. And I'm going to turn it over to Alana, and she's going to talk about her clinical practice and how the impact of consultative physio services to the two First Nation communities that she works in. And then she's going to do a reflection on health equality. Okay, so like I said, I was born and raised in Churchill. So if you look up here, it's just on the coast of Hudson Bay. It is only accessed by plane or train. And I work for an organization called Manitoba First Nation Education Resource Center, or MFNERC for short. Within the organization, there is a special ed program that consists of a team of facilitators who develop programs and provide supports to educators working with special needs children in First Nation schools. So our team includes speech language pathologists, occupational therapists, physiotherapists, school psychologists, student support, also known as social workers, special ed facilitators, deaf and hard of hearing facilitators, literacy coaches, and audiologists. So currently we have 6 physiotherapists on staff. I work in 7 different communities all over Manitoba. So the most southern community I work in is called Roseau River. So it's about half hour south of Winnipeg. So I don't know if you can see my mouse, but it's down here in the light blue. And then I would say one of my northern communities is York Landing First Nation. And I'm not sure if you can see my mouse, but it's at the top of the yellow, kind of in this area. So it takes 2 flights to get to York Factory, or York Landing, pardon me. So as MFNRC PTs, we try to travel to each community every 6 to 8 weeks. So within the 7 communities I travel to, 4 of them I'm able to drive, and then I have 3 that are fly-ins. So I just want to take a quick second just to show you some of the communities that I work in. But with MFNERC, we work in all of the First Nation school communities. So if you can look here, the most northern community I work in is York Landing. So it's kind of at this yellow point here. I also work in Oxford House. That's kind of at this group of communities over here. And several others. So you can kind of see from the map here that some of the communities are far from any city center. So Winnipeg being down at the bottom, and also Thompson being the northern hub. Okay, so impacts on services to speech children. This article from CBC was published recently, April 28, 2019, and the title is Lack of Teachers, Internet Puts Garden Hill First Nation Students Year at Risk. This article was discussing how community members and school staff were describing the conditions in Garden Hill First Nation, which Alana will touch more on this on Garden Hill later. Since COVID-19, schools have been closed and physiotherapists have turned to technology to help deliver their services. MFNERC staff, we have been grounded and working from home since March 16th, 2020. I'll be talking about the 3 challenges that have impacted our services to school-age children. So one of our first challenges is some of the families I work with may not have access to internet. So if they do, the connection is poor due to the bandwidth, and therefore it is a challenge for video calling. Especially with our northern communities, if I can name a few, is Tiduli Lake, York Landing, Chamalawa, Lac Rocher. Those are just a few that we work with. And since working from home, even in Winnipeg, I find my own Zoom meetings may have a lag or become choppy. In a previous webinar by Dr. Sean Cleaver and Dr. Hunt, they have discussed in their webinar called Ethics and Equality Within the Practice of Physiotherapy that this can create a bigger divide in providing services. So the solutions that we were trying as an organization is providing digital and non-digital resources to the families. So for the non-digital, we were relying on mailing our packages or connecting with resource teachers to help hand out the resources to families. Our second challenge that we found is that some teachers are not physically in the community. And that article that I have on the screen kind of goes a little more into detail of that. So one way for students to receive their recommendations or schoolwork is teachers or resource teachers handing them out physically. Since Manitoba province restricted travel to northern Manitoba on March 20th, teachers that are out from the community were on spring break. And now those teachers may have a difficult time returning to the communities they work at. So the solution that we were trying to find is to help support families to the best of our ability is still reaching out to teachers that are still in the community or even to the band and council, just to help further reach out to those families. Our third challenge is parents are feeling overwhelmed. Homeschooling children can be overwhelming, especially if parents are working from home full time and now that they have to homeschool their children, especially if you feel like you don't have the right access to resources or support. So moving to a technology, need to do that. There we go. So moving to a technology-based intervention and treatment can be overwhelming. And one of the examples I can think of is informed consent. So this article by Lisa Bovin and Jana McLaughlin illustrates the complexity of informed consent within Indigenous population. Generally, healthcare professionals envision the consent process to look like this figure. You're giving them the information and they understand. However, they found that many Indigenous people experience the consent process more like the second figure, where they're getting bombarded by information. I found this article very interesting because this is how I was feeling with getting informed consent from families within my own practice. So one of the solutions that we're trying with MFNERC is for our high need students, we are assigning a case manager for each student. This will limit the numerous calls that families would receive from clinicians. So for example, if one student is referred to an SLP, an occupational therapist, maybe a physio and a school psychologist, we don't want the families to get 6 different calls. Therefore, one of the clinicians will take the role as case manager and reach out to the family and see how we can best support them. Now, lastly, I just want to quickly touch about Jordan's principle. I'm not sure if everyone's familiar with Jordan's principle, but I thought I'd spend some time talking about it because in Manitoba, and I can't speak for all the other provinces, it's a major resource for our First Nation communities. But first I'll talk about how Jordan's principle was created. Jordan's principle is a child first, needs-based principle that applies equality to all First Nations children, residents on and off reserve. It ensures that there is no denial or delay for First Nations children to receive essential public services that are available to all children by having the government Department of First Contact pay for the services. So Jordan River Anderson was from Norway House Cree Nation, was born in Winnipeg on October 22nd, 1999. His parents lived in Norway House at the time of his birth, and Jordan was born with a complex genetic disorder called Carey-Finman syndrome. Due to his complex medical history, he was not able to return to his home community. While the federal and provincial government were disputing the cost of care for Jordan, he died in Winnipeg, February 2nd, 2005, never being able to go home to Norway House. So implementing Jordan's principle was identified as one of the first 5 calls to action on First Nation child welfare for the TRC. Within each First Nation community in Manitoba, Jordan's principle programs are unique to each community. So for MFNERC, the special education program is primarily funded under Jordan's principle. I thought I would talk about Jordan's principle. And then within each community, they have supports within the school. So that would be MFNERC staff, and then they also have community supports, Jordan's principle community clinicians. So it may look different in every community, but typically we will collaborate with the Jordan's principle community clinicians with students entering school, students that are not attending school, or kids that need the additional support at home. And now I'm gonna let Alana take over.
All right, so I'll just share my screen here. So thank you, Priscilla, and hello, friends and colleagues. So I'll begin as well with a little bit about myself. My name is Alana Beavis, and I am of settler descent, and my ancestry is Western European. And I strive to practice critical allyship. I am one of the co-representatives for the Indigenous Health Subcommittee with Priscilla. Being a part of this subcommittee was very important to me, not only for my own learning journey, but also because I feel it's so important for us to have Indigenous perspectives within our national organization, and also as a step toward health equity. So where am I from? I am from a small town called Pilot Mound, Manitoba, which is 20 minutes south of Swan Lake First Nation in Treaty 1 territory. So if you direct your attention to the blue part on the bottom of the map, I'm the little yellow star in the corner. And when I was in grade school, I moved to LaSalle, Manitoba. It's a bedroom community of Winnipeg. I went to high school in Winnipeg. I moved to Hamilton. I went to McMaster University for my Bachelor of Health Sciences degree. I also stayed at Mac to do my master's in global health. And then I went to University of Toronto to do my master's of science in physical therapy. Started my practice in Northern Ontario and then moved back to Manitoba around 2017. Since then, I have been working for Community Therapy Services, which is a private not-for-profit organization located in Winnipeg. So one of my roles within this organization is within the Northern Outreach Program, where I fly to 2 First Nations communities. These communities are in what's known as the Island Lake region, and they are Garden Hill, so there's a little yellow star that just popped up, and also Red Sucker Lake. So both of these communities are signatory to the 1909 adhesion to Treaty 5. They do not have all-weather road. There is access by a winter road in the winter, but otherwise the only other access is to fly into the community. So we at CTS receive public funding in order to fly into these 2 communities at a frequency of once every 4 to 6 weeks to provide services within the local nursing stations. So both of these communities, their health facilities would be nursing stations. To the best of my knowledge, I am the only physiotherapist providing community-based physiotherapy services for adults. As Priscilla mentioned, there are organizations that receive funding through Jordan's Principle to provide community-based physiotherapy services for pediatric clients as well. There are some opportunities for rehabilitation off reserve, but they are limited. So there are some intensive physiotherapy opportunities in Winnipeg, but this has changed quite a bit in the last few years. In 2017, most of the outpatient physiotherapy departments were closed in Winnipeg. So I believe the only one remaining open is Health Sciences Center. So sometimes I have clients that go there. There are no local private physiotherapy clinics, and even if there were, NIHB does not provide, NIHB is the non-insured health benefits program. They do not provide funding for private PT services, and medical transportation wouldn't pay for a client to go down to Winnipeg to go to a private clinic. So what this results in is residents in Garden Hill and Red Sucker Lake experience inequities with regard to accessing physiotherapy services. This unfortunately is not an uncommon experience for northern rural and remote communities. So we at CTS, we recognize the value of providing our community-based services to these communities, and we continue to advocate on an ongoing basis to increase funding in order to expand service provision for the First Nations communities that we serve. So I thought I'd take a fun break here and give you an idea of what do these communities look like? So we're looking south, and this is Garden Hill First Nation. In the top right, we've got the landing strip. That's where the airplanes land. You get off, and then we hop in a car, or a truck really, and go across the winter road over to mainland, and you can see Garden Hill pictured on the left. So during freeze up and breakup times of the year, we take a boat across. We also take a boat in the summer. Sometimes when you can't take a boat quite yet, you also take a hovercraft. So it's always an adventure heading into these communities. So how is COVID-19 impacting on PT services to these two communities? Both Garden Hill and Red Sucker Lake are on lockdown. So there are travel restrictions for residents to and from, and also within the community. It's really important to pause here to realize that a decade ago, the Island Lake region specifically was hard hit by H1N1. There were 11 deaths in the province, and 3, possibly 4, were in Garden Hill First Nation. So these communities are rightfully very concerned about the impact that COVID-19 could have. And as well, there are many within the homes, there are often multiple generations living together, and some houses don't have easy access to running water. That makes it quite difficult to follow some of the public health recommendations. And there are people living in these communities that if they were to contract COVID-19 due to a health condition, they may have a poorer outcome. So I really commend the bands and councils for all that they're doing to try to protect their community. I also want to highlight here how we in southern and urban settings really have a big responsibility to follow the public health orders. The longer that COVID-19 is transmitted in urban and southern settings, the greater the opportunity for the virus to get into some of the other First Nations communities. So there are also travel restrictions that affect healthcare providers, such as myself. So up until quite recently, we had public health orders in Manitoba whereby you couldn't do non-urgent or non-emergent physiotherapy services, but that changed May 4th. So May 4th, the Premier announced some reopening, some gradual services in Manitoba, and one of those was the reopening or resumption of non-urgent and non-emergent care for physiotherapists. And the reason I bring this up is because a lot of my outpatient consultative services would be looking at a chronic knee or chronic back pain. So it might fall under what was previously considered non-emergent. But even though these restrictions have lifted, there are many other factors that influence my ability to provide service in these communities, including travel restrictions north of the 53rd parallel, accommodation availability, and also getting approval from band and council to access the communities. I'm in frequent contact with the nursing stations and nursing managers to see, when can we make a plan to resume. I'm hopeful to be able to resume, hopefully in the not so distant future, but we don't really know when these restrictions are going to fully lift. So in the meantime, we're looking into some existing infrastructure such as Manitoba Telehealth, as there are many facilities that have this technology. So I believe both nursing stations that I go to have Manitoba Telehealth. I'm also working remotely on some equipment orders. As I order quite a bit of equipment through non-insured health benefits. I'm also available by phone to the nurses at the nursing stations if they need to do any consultations. I want to take a quick moment to talk about how telerehabilitation has been something that's really been hyped in our profession right now as an answer to providing service. But as Priscilla mentioned, telerehab really has to contend with some very real infrastructure barriers in northern Manitoba. So Red Sucker Lake doesn't have cell phone service, therefore no data and no Wi-Fi unless you have your own router. In Garden Hill, the bandwidth is not reliable and not everyone has the computer. So platforms such as Zoom and many others really aren't feasible in this context. So what I might say here is that maybe there's an opportunity for our profession to engage in internet rights activism as it relates to telerehabilitation, given the inequitable access for our physiotherapy clients. But to end on this slide, I would like to say that COVID-19 deepens and holds a magnifying glass to the inequities faced by Indigenous peoples living in remote parts of Canada in terms of accessing PT services. And I really wanted to reflect a little bit on health equity. I'm not going to deep dive here. As Priscilla mentioned, Dr. Cleaver and Dr. Hunt really dove into this in their webinar. So if you haven't had a chance to read it, watch it rather, I would suggest. But I do want to talk a little bit about what is what is a health inequity. And we can understand it as an unfair, unjust, and preventable systematic difference in health. But what creates these unfair conditions in a society? There are unjust social structures that operate in society that confer an advantage to some people and a disadvantage to others. Colonialism is one such structure and is a critical determinant of health for Indigenous peoples living in Canada. And I really want to highlight how colonialism isn't just something that happened in the past. It continues into the present and impacts upon the lives of Indigenous peoples in various ways. So we can and have a responsibility to disrupt and dismantle these social structures. We can do this by in social justice and practicing critical allyship. We don't really have the space here in this webinar to deep dive into that, but we have there are some great resources out there that can help guide in this journey. And one of my favorites is the Indigenous Ally Toolkit, which is pictured there to the right. There are also additional resources on the Global Health Division website. If you go to the Indigenous Health Resources or Indigenous Health Research page, there's lots there. So that would be a great way to further your journey. And just to end on a tweet that I just really like, it's by Marsha J. Anderson. And she says, from now on, instead of vulnerable people, I'm going to use the phrase, people we oppress through policy choices and discourses of racial inferiority. It's a little bit longer, but I think it will help us focus on where the problems actually lie. And I love this for so many reasons. The word vulnerable is being used quite widely right now. My concern is people that might only think of vulnerable in terms of biology or in factors that are intrinsic to a person, like their health and age. But the COVID-19 pandemic really offers us an opportunity to reflect on and analyze how unfair social structures play a role in determining who might contract COVID-19 and what their outcome might be, but also how it exacerbates inequalities and inequities in terms of access to physiotherapy services. So by changing the phrases and the words we use, we can put the emphasis where the emphasis really needs to go, which is on health equity. And here are some of the references that we used in today's presentation. And we will end by just thanking you all for being here with us today. As I mentioned, we're the co-reps for the Indigenous Health Subcommittee. Feel free to reach out to us. We share an email address, ghdindigenous@gmail.com. We'd love to hear from you. So thank you.
Amazing. Thank you so much to both of you. And I really like that tweet that you put up at the end, because I hear that all over the place too. And I hate the term, like when people say vulnerable people. So I like the alternative. So that was great. Thanks for offering and giving some insight on your experiences. Now so if anyone has any questions, you can type them in the Q&A. And I just wanted to clarify something. Did you say a hovercraft?
Yeah.
Okay. That has to be one of the first global health experiences that has a hovercraft involved. I think everyone
I thought that was pretty
signed up right now. That's pretty cool. So now there was a question. So Jen O'Neill posted, so question for Priscilla, can you expand on the non-digital package for physio?
Yeah, I could definitely do that. So we're trying to provide non-digital resources to the families. We are still in the process of trying to figure out what that includes. So since we've been working at home, we've been creating resources like different handouts of activities kids can use with the ball, pretty generalized resources that kids can use in their house, and hopefully they have the equipment that they need. But we're just trying to brainstorm different handouts that if the parents want them, we have them on hand. If they don't, then we're just trying to support the families as best as we can. I hope that answers your question.
Let me ask thank you for that. And let me ask the next question. I think there might be more coming on here. But I'm not sure if it was Alana and Priscilla, but you said something very important around digital advocacy. So, and experience for a lot of us on the call today who've worked in many countries where access to the internet is spotty, it's not robust, and here we have it in Canada, right, in our own communities. So therein lies an inequity. But so how do we, can you go down the path a little bit more of how we would collectively advocate for that? And in the absence of full internet for all as a human right almost, how do we maybe think about like a health center in some of these smaller communities where people could gather and then access to others, so that it's not about all households, but certain parts of the community. But do you have any thoughts on that question?
So I think it was myself who brought up internet rights activism. And when I first came across that term as I was looking into this, it was with relation to schools and what schools are doing. And I know there's some internet rights activism right now about education for families that are having difficulty accessing online materials. So I didn't really dive too deeply into what that might look like for our profession. But I think, when we consider our role as advocates for our clients, not just advocating within healthcare, but also within other sectors in society, because they all interplay. So in terms of what I thought of activism might look like reaching out to other sectors in society, other industries, infrastructure. Why is there that inequity? Why, when you're living in northern Manitoba, do you not have the same access to cell phone service and internet? But you make good points, is that there might be centers where you could go, for instance, to have a group class. But I think when we're thinking about clinical services and privacy, I can see how you might need more one-on-one interaction.
Just as a little follow-up, and we'll set up maybe the next question with Phil there, but in certain areas now in disaster zones after a sudden onset event, there's a company, this is my pitch, maybe like what you think about a public-private partnership with local communities, but there's this company, it's called Loon, like balloon, so Loon, and they will float these whatever, I can't remember what it's called, but these are these sort of weather balloons that they'll float with transponders on it. And so for a certain amount of time, you can get full access to the internet while they're floating in a geographical zone. So imagine on for instance, a Tuesday or some random day, when you're there or when you're not, or some strategic point in time, that we figure out a way that you actually have some innovations so that we can actually get internet access to very, very remote communities. And I'm just thinking, Priscilla, you showed a map that, your environment is only halfway up. There's all that other space, like who and how do we access there? Because as Canadians, we all pay taxes, and so we all deserve equal access. Yeah.
Yeah, and with MF and ERC, those are just the communities I travel to. I know there's other clinicians going to those higher or more northern communities, but you do raise a really good point.
Great. So there are actually a few questions that came in about on the internet activism, and I think that's going to be the new term going forward after this one, along with Alana's tweet. So another question that came through here was so from Barbara, who said, Alana, do you find the NIHB program getting tougher on access to equipment for adults in Manitoba? I deal with them in Northern Ontario.
So one of the changes in the last year was that they made it easier for prescribers. So as a physiotherapist, I no longer have to go through a doctor to get their signature in order to prescribe equipment. So that made access easier. I I often check the list of what is available through the program. I'm not sure that I've seen much change with respect to walking devices, orthotics, like those kinds of things in the last couple of years. So my experience in the last 3 years of working in this role and ordering through NIHB, I haven't seen much of a change in terms of difficulty accessing that equipment for adults. I mean, you do have to sometimes justify what you're ordering, and so some justification processes take longer than others, so that can sometimes be a bit more of a delay sometimes, but I haven't found much difference other than that. I don't know if, Priscilla, if you, I know that you would typically work with peds, but I don't know if you have any thoughts on that as well.
For peds, we don't really have any difficulty with it, NHIB, but we're usually ordering equipment that they, like for example, walkers. I ordered a lot of adaptive bicycles. I think recently I just put in adaptive hockey skates and sledge hockey equipment. So hopefully soon I'll be able to hear if they accepted those funding requests.
For those of us who don't know, can you define what that is, please?
Define.
The NI.
Alana, you might have a better chance with this.
Sure. I think it's a non-insured health benefits program. It's operated by Health Canada, so it's federally funded for Indigenous peoples.
So it's a federally funded project or program that comes right off the federal budget line, not any province or territory. Okay.
Yes.
Thank you.
I thought you were asking to define sledge or skates, but I figured that was like the most Canadian comment I think I've ever heard. Yeah, I put in an order for adaptive skates and sledges for sledge hockey.
Yeah, you know you're in Canada when.
Yeah, exactly. So so there's another question from Lisa here who says, what do you feel might be the role of the CPA as an association representing the profession nationally in advocacy for Indigenous rights as a means of deconstructing structures which oppress Indigenous peoples and lead to health inequities? Good question.
Great question. I could probably take an initial stab at it. I think one of the very first things that we could do as a profession is really embrace and endorse the Truth and Reconciliation Commission's call to action. For those who aren't familiar with the Truth and Reconciliation Commission, or TRC, there are many calls to action for healthcare professions, and we had several people write within our profession. I think it was 2015, they published Mobilizing Reconciliation, where they break down for us which calls are relevant to our profession and how we might rise to meet them. So I think we have a real opportunity here to rise to the occasion, to understand that these health inequities are, they're present and they've been deepened by COVID-19. So we have this opportunity to really galvanize and endorse and embrace the TRC calls to action, but also to really bring Indigenous perspectives within the consciousness of our national association. I think there's a beautiful opportunity here for capacity building and moving forward in that spirit. So that's my thought. I'll pass it over to Priscilla in case you have anything to add.
It was beautifully described. I don't know if I have anything else to add there, but yeah, just trying to implement Indigenous. That's a hard question, but yeah, you did a really good explanation, Alana.
Thank you.
So before Phil goes to the next question, can I ask the two of you, and maybe specifically Priscilla, given your Indigenous background, are we as a country doing better today than we were 5 years ago? Like, are we on the right path, in your opinion, from maybe a very narrow physiotherapy perspective? Are we on the right path, and how do we support more, and how do we think about this in a greater context?
That's a really good question. And I might have a narrow answer just because I'm still pretty new to the profession and new to the subcommittee. Like I said, I graduated in 2018, so to be honest, I haven't even been a physiotherapist for 5 years, but I'm sure we came a long way, but I feel like there's a lot of things that we can improve on. I know, like, even at a CPA level, coming up with different goals and coming up with like a plan to implement the TRC. But yeah, Alana.
You know, I think that there's been some good first steps. I think that as a profession, really sinking into and yes, like I mentioned, the TRC calls to action, like really sinking into that and what that means for us. And I think even I might be quoting the article here, but it kind of speaks to our maturity as a profession in terms of how we respond to this. So I think that we've taken some good first steps, but I think that there's further that we can go. I think within our profession, there are some excellent researchers that are really champions of these topics and health equity. So we've got a lot that's specific to our profession that we can, go to and reference. So I think that there's a lot of champions, and I know that there is a really passionate group of people in the Indigenous Health Subcommittee, which I'm very grateful to be a part of and to work with them. So, and others, there are lots of allies in our profession. And I think really, I think one of our essential competencies is advocacy. And so I almost start to think, maybe going beyond that, and should allyship be a part of that? Should we, advocacy is so important, but as a profession, we could be really embracing what allyship means as it relates to many different, especially to Indigenous peoples, but there's so many ways that we can be an allyship with so many people in Canada.
Churchill said, never let a good crisis go to waste. And so the undertone of my question is, how do we use an opportunity, tragically, of what's happening now with COVID-19 to advance some really important points around equity? And I agree with what you both said around what Sean and Matthew were talking about. So how do we use this as a springboard? And let's go to some questions, but I think what you just said was pretty powerful and really made me think. So I appreciate that. Phil?
Yeah, that I really appreciate it too, and like the that you highlighted kind of the small steps that are taken, but still the work that needs to be done. So there's a question here from Diana, who says, so is it of concern that despite the current environment of government supporting COVID-19 needs with financial assistance, they have not put any funds at rural and remote internet services? I guess like just to add on to that. So do you think that is something that needs to be a focus from the government? And you mentioned that is something that physiotherapists and we have as a profession can do, is really advocate for this. And what ways do you think that we can do that? So maybe we'll go to Alana first and then Priscilla.
Well, I think probably within our profession, well, really, I think it's reaching out and lobbying other sectors, explaining, here are the inequities that exist, and here are the consequences of those inequities. And so I think engaging in advocacy, not just within our profession, but into other sectors, because we don't exist in silos. Healthcare is impacted by many other operating parts in society. So that would probably be one of my main responses. I haven't really operationalized entirely what I envision all of that looking like, but I think it's a big question, and I'm glad that we're kind of thinking into it. But maybe I'll pass it over to Priscilla.
Hi. Yeah. I think I'm reflecting back on our profession as physiotherapists, and I'm trying to think of how the people don't have access to internet, and how the internet connection is really affecting my service. And so when I collaborate with my colleagues, like the occupational therapists and the speech and language, I find that they're able to develop very generalized recommendations that are be able to help a wide group of students. And with physiotherapy, I find that we're more one-to-one rather than more a general. We need that one-to-one intervention, and using the internet and having that video call really helps, especially if, for example, if you're doing exercises. It's nice to get that visual feedback rather than just a phone call to the family. I don't know if that answers your question, but that was my little tangent of internet.
Yeah, that's great. So, Mike, did you want to go for the next question, or
Yeah,
just
sure.
on the list?
I'll ask, this is from Lisa Arcobelli. Also, would you be able to share more about what NIHB is and how it compares to the health resources and non-Indigenous Canadians that have access to? So maybe just a few points around, and Moni, if you look at the chat, made a point around this, around this is a specific fund that you need to qualify for by being First Nations, I believe. So can you just for a few moments, just mention that?
Beyond the description I gave earlier, I think that even I don't know all the specifics or in and outs of how this functions, but and I think there's even there is eligibility criteria, but I can think of a specific case where someone who had Indigenous heritage for some reason didn't have access. So I think there's some nuances beyond having treaty status and not having treaty status. I think there's even some nuances there. So I'm really not the best person to dive into what is the eligibility and what's fully accessible. I understand what's accessible through that program as it relates to physiotherapy and the equipment that I order, but I don't believe I have the best full perspective. I don't know, Priscilla, do you have more to offer on that?
I apologize.
No.
I probably don't have a great answer to that question.
No problem. If you look at the chat, so I'm going to reach out to Lisa and Moni that you all know there in Manitoba, and we'll come up with maybe a framework of what this means, because I'm quite interested myself. Listen, I'm embarrassed. I didn't even know about this. So let's use it as a learning opportunity, and thank you to Moni and others for bringing it up. So Phil and I and Jenny will take it offline. We'll make sure we get information out to you all. So thanks for that. Phil, next question.
Yeah, thanks. So this is from Josina, and she asks, Alana, before COVID restrictions, how often did you go into the communities? Did you use telehealth, so like phone, video, email, at all before COVID, between visits? And so have you found that using telehealth has changed how you connect with your clients? So 3 questions there. So before COVID restrictions, how often did you go into those communities?
So pre-COVID, every 4 to 6 weeks. So that equates to approximately 10 trips a year. and that's between the two communities. So usually I fly into Garden Hill, and I get 2.5 clinical days in Garden Hill, and then I fly in the afternoon over to Red Sucker Lake. I've got a clinical day in Red Sucker Lake, and then I fly back to the airport, which is just north of Winnipeg. So, and it's consultative. So a lot of what we're doing is not necessarily carrying a large active caseload. So a lot of times when you're going into each visit, you're seeing a lot of new people each time. Although, you know, this is not the first time our services have been disrupted. I have had to cancel trips before because of inclement weather. Once a forest fire, another time when the electricity was out in the entire community for weeks on end. So, you know, this is not the first time that we've been disrupted and recovered, but I think that, you know, if the situation is ongoing and we can't travel for a greater length of time, then that would for sure be the longest that I haven't been able to go. So that would be a bit of a different situation. But to clarify, a lot of what I do are on-site clinical services. So there's not a lot that happens in between unless I'm following up on an equipment order. So not really, I haven't used telehealth before, but we're thinking, you know, if the situation persists, then we may have to look at whether the infrastructure might work for us in that program.
So what would be your opinion? So in terms of access, you know, complicated now, and I see Sandra is asking questions around sort of, you know, numbers of patients who might have tested positive, and although even testing capacity, I'm sure is strained from a resource perspective. But what do you think the downstream effect might be from
Oh, I think
are you foreseeing some downstream effects? Am I back? Good.
You're back now. You
I'm
kind
sorry.
of froze for a second.
Yeah, it's better if I'm not visual here as usual. So, but the question is really, do you foresee some major issues downstream among your populations who are not able to access care?
well, I think the most obvious one would be for people who need who have an acute condition, or if they've had some kind of surgery and come back to the community, then not having that timely access to physiotherapy services would more likely result in a poorer outcome. So I think those would be my main concerns, is you know, not being able to access people who have more urgent cases, and which we sometimes do see. Sometimes people come back to the community after having surgery. So I think that would be my biggest concern, is people having poor outcomes due to lack of access to timely rehab.
Nice. Thank you. So that's pretty much, so if there's any more questions, you can type them in there. And I do see there are a lot of people here that have quite a bit of experience within working with Indigenous communities and in rural settings. So I even see there's a lot of discussions in the chat happening too. So now so Sandra asked the question about any cases in respective communities now. You kind of touched on that, but well, you can add to that. So right now you said there weren't, right?
Yeah, to my knowledge, I don't think there's any COVID cases within First Nation communities in Manitoba.
Yeah, okay. Sounds good. So if anyone has any last minute questions, and you can type them in, but if not, then I think we'll wrap it up here. And just wanted to say thank you for coming in. And where can people find more? Oh, there's maybe one more question, but where can people find more information on, say, the Global Health Division and the Indigenous Health Subcommittee, and hear more about what you're up to?
Yeah, so I would say head on over to the Global Health Division website. There are a lot of resources there. You can look at the different execs that are on in the Global Health Division executive, and also there are lots of resources for global health, for Indigenous health, for many other topic areas as well. So I would go over there. And so you're also welcome to reach out to Priscilla and I at our email address, ghdindigenous@gmail.com. So we certainly, if you've got an interest in this topic, we're also always looking for people who endorse the Indigenous subcommittee goals. The goals are also on the website. Who endorse those goals and who are passionate about health equity and Indigenous perspectives. We are always looking to grow our Indigenous Health Subcommittee group.
Amazing. Thank you. And yeah, we'll look forward to hearing kind of everything from the Indigenous Health Subcommittee and the Global Health Division. And really thank you for sharing your experiences. And it's incredible the work that you're doing. And I'm excited to hear how everything goes kind of as things progress through, as we're dealing with COVID, but also afterwards. So maybe if we're still doing these sessions, we'd love to have you on after to share your perspective on that too. I see Mike's laughing at that. Who knows how long this will go on for?
Yeah. Well, let me just echo Phil. Thank you, Alana. Thank you, Priscilla. We'd love to have you back on the show if Phil and I are still alive at the time. It's, as we said in previous sessions, this has been, and again, Jenny Day has been just a godsend to us and really has been huge in helping us. But we're very open to having this change where we even have guests, facilitators on, and would love, for instance, wouldn't it be amazing, Phil, if Priscilla or Alana would somehow be able to maybe bring virtually somebody who is a First Nation, a patient of theirs who lives in a First Nation community to really talk to us, because this is not a small issue. Like we're talking about it in the context of COVID-19, but it exists way beyond that. And certainly, again, I didn't mean any disrespect by saying we can't let a good crisis go to waste, but now could be a time for us to say, well, let's move, let's figure this out. And you know, as a settler myself, I'm not sure, I certainly don't have all the answers, but I want to learn. And if we're all coming in with that perspective, I think we a better nation, a better community. So I just really enjoyed this. So I thank you so much, the two of you.
And thank you for inviting us on your guys' webinar. It was a blast.
Yes, we've both been looking forward to this, so thank you so much.
Our pleasure. And thanks everyone for being here. We'll make sure to follow up on some of the things we talked about. And this video will be posted online, and we'll see you on Thursday and then again next Tuesday. So thanks again, Priscilla and Alana. Have a good night, everyone.